Good afternoon. I-share ko lang po, sabi ni Julius, yun daw picture ko parang si Rosana Roses na bagong gising. Hindi ko naman alam kung saan kinuha yun. Anyway, I've been given the topic of the safety of the dengue vaccine, concerns and consequences. I could not say no to my dear Dr. Jing and Cindy Ama. Maski alam ko, ngayon lang po ako inabot ng lingguhan to prepare. These are my disclosure of interest. Okay. You know, in dealing with vaccines, in our effort to prevent illness and save death, we encounter adverse events, side effects, and unexpected reactions. And just to put things in their proper perspective about the basics of vaccine and vaccine safety, I will give you a brief background. So immunization, particularly childhood immunization, has been one of the most successful preventive health measures in this century. And as I always say, and I always firmly believe, that an ounce of prevention is definitely worth more than a pound of cure. Recommendations for vaccinating infants, children, adolescents, and adults are actually based on the characteristics of immunobiologicals, the scientific knowledge about the principles of active and passive immunization, the epidemiology of diseases, and judgments of public health officials and specialists in preventive medicine. Benefits, as stated by Dr. Lazo earlier, benefits and risks are associated with the use of all immunobiologicals. So no vaccine is completely safe nor completely effective. Benefits of vaccination range from partial to complete protection against the consequences of infection, resulting from an asymptomatic or mild infection, to severe consequences such as paralysis or death. Risk of vaccination range from common, minor, and inconvenient side effects to rare, severe, and life-threatening conditions. Thus, recommendations for immunization practices must balance scientific evidence of benefits, costs, and risk to achieve the optimal levels of protection. Actually, this was already discussed by Dr. Lazo as well, but I just want to emphasize that the development of vaccines must be held to a high standard of safety and that there are stringent measures to ensure the quality and safety of vaccines. Of course, just like any other pharmaceutical product as well, vaccines are carefully evaluated for effectiveness and potential harmful effects in vitro and in animal studies. And once good results is achieved, then these products get into phase trials with humans then begin. Once the vaccines are licensed for general use and administered to large populations, it is very important that monitoring continues, as this was emphasized earlier on as well. Remember that clinical studies are only for a limited period of time, and there may be less common adverse events or rare adverse events that may not have been identified during the clinical trial. Thus, it is important that when there's more universal vaccination, when there are larger populations that are now immunized, it is important that monitoring continues to be able to identify these less common adverse events, events that may occur after a long time that the vaccine is being administered, or events that occur in specific subgroups of target population. Numerous regulations actually ensure the safety and quality of vaccines, and this was discussed earlier as well. So I'd just like to say that where we choose to focus makes all the difference in what we see. So, to start with the main topic, we will just look at first the reality of dengue, the burden, and then look at the vaccine development, and of course, vaccination safety, some of the concerns and consequences. We know that dengue is indeed a public or a global concern and remains to be a public health challenge. Now, the World Health Organization says that early detection of outbreaks is essential to reduce the staggering human and economic cost that is associated with dengue. Now, the global community has actually responded to this and has begun its fight. So with the use of digital technology, people all over the world are now able to track the record of dengue outbreaks. So they know what's happening. So this is the latest data that we have on dengue, that dengue still persists in our country. But unlike before, if you will see the lower part, the highest cases of dengue is not as high as what we saw in the National Capital Region before. You would see that the highest cases are in Region 7, and then there's Region 7, Region 6, but in Region 3A, it still continues. However, you will see that in the National Capital Region, compared to that of 2015, it actually decreased. And again, of course, there's still no sex predilection, and that the highest cases are seen in those younger children, 1 to 4 years, or those less than 4 years of age. Okay. Now, because the burden of dengue is very real, it is this reality that has actually, or has brought about the development of the dengue vaccine. Now, this was also mentioned earlier that guidelines for clinical evaluation of dengue have actually been developed. And this came from individuals, experts, institutions, and communities whose aim is to identify basic technical information that is required to be able to come up with dengue vaccine field trials. Okay. Well, just to point out again that vaccines, just like any other pharmaceutical product, actually undergoes extensive testing and review, specifically vaccines, review of safety, quality, and efficacy. And they undergo phases of the trials up to phase 4, which is actually more the post-licensure surveillance. Now, there are many dengue vaccines now in clinical development. The most advanced is the dengue vaccine that is currently licensed because it's the only one that is licensed. And several other vaccines are actually in development as well. And the second vaccine that is in sort of near the phase 3 licensure state is the Takeda vaccine. It is now in phase 2 clinical trials. So these are a list of other dengue vaccines that are now being investigated. Okay. So again, no vaccine gives us 100% protection. As mentioned, we need to strike a balance between efficacy and safety. So judgments of practitioners is very important to be able to strike a balance. Now, as an example, and this was mentioned by Dr. Lazo as well, if you look at polio, for example, the risk seen with vaccination, and this is a real risk, that these patients may actually develop a vaccine-associated paralytic polio with the use of the oral polio vaccine. Then we have the circulating vaccine-derived poliovirus, particularly if there is inadequate or insufficient coverage. Benefits of vaccination include a decrease in the incidence of polio, around 10 times less ability to enter the central nervous system compared to the wild-type virus, and that the ability of the oral poliovirus to actually cause a higher level of mucosal immunity. And of course, the easy administration of the vaccine. And that polio is, in fact, the oral polio vaccine, rather, is responsible for the near elimination of polio. Of course, the reality that there are about 10 billion doses that have been administered, and there's a decrease of about 99% of polio cases since 1988. So that there are about 13 million cases of polio that have been prevented. So despite the real risk of getting vaccine-associated paralytic polio, or your CDVP, we continued to use the oral polio vaccine because we know that it decreased disability and death. So it seems that indeed we can see that benefits of the vaccine outweigh the risk. What about the rotavirus? Again, we know that there's the risk of intussusception as far as rotavirus vaccine is concerned, and this is usually seen in the first dose of the vaccine. Benefits, there has been a substantial reduction in rotavirus gastroenteritis, particularly in countries that have used rotavirus vaccination as a universal program. And that in Mexico and Brazil, they have noted a 22 to 28% reduction in diarrhea and deaths in children less than 2 years of age. Thus, the vaccine provides protection against severe rotavirus gastroenteritis for at least 2 years, which is actually the period of highest risk for rotavirus gastroenteritis. So the reality is that globally, it is the leading cause of diarrhea, rotavirus, and that during the pre-vaccination era, more than 2 million children were actually hospitalized for rotavirus infections. The World Health Organization recommends the rotavirus vaccines to be included in all national immunization programs. So again, we can see that the benefits of the vaccine actually outweigh the risk. Okay. So the risk, you can see that the risk of acquiring illness, injury, complications are actually far more greater when you get the actual disease than when an individual is vaccinated. Also, we have seen that there is a dramatic decline in morbidity and even mortality when vaccination has been implemented for all of these vaccine-preventable diseases. What about the dengue vaccine? Okay. The reality is that the number of dengue cases has been increasing for the last 50 years. Now, the World Health Organization has recommended that the dengue virus or the dengue vaccine may actually be considered for introduction in geographical settings, whether national or subnational, where epidemiologic data indicates a high burden of disease. And in that recommendation, they say that if you have a seroprevalence rate of more than 70%, then the dengue virus vaccine can actually be given as a national or subnational program. Also, they have mentioned that if seroprevalence data are not available, because generally we don't have seroprevalence data, other epidemiologic markers may be used. For example, you look at disease incidence, you look at the fact if there is continued transmission, you look if there is circulation of all the 4 serotypes, you look if this disease is actually imported or is it local, etc. So there are other epidemiologic markers that can be used in deciding whether you implement the dengue vaccination program, apart from seroprevalence. Now, what about the benefits of the vaccine? The studies that are available, the evidence that we have is that it has actually demonstrated its efficacy, providing a 65% protection against symptomatic dengue and a 93% protection against severe dengue and about 80% reduction in cases of hospitalization due to dengue. And that this efficacy has been shown regardless of the serotype or previous exposure to dengue, because we have shown that even among seronegatives, there's about a 52% vaccine efficacy. Now, what are the vaccination risks that we are concerned about? So potential risks that we know are one, and this was proven and shown in the study, that there are safety signals of increased risk of hospitalization on year 3, which is the first year of follow-up, among children 2 to 5 years of age. Of course, there's the theoretical risk of antibody-dependent enhancement of the infection. I say theoretical because as far as the available data is concerned, there is no evidence to show this, which we will see later on. And of course, neurotropism and viscerotropism. So with all of this, do we think that the vaccine is safe for use? Okay. First concern, the vaccine has the 4 dengue viruses. Can this really transmit the dengue and all 4 serotypes? The straightforward answer here is no, because the potential risk that is associated with a live attenuated recombinant vaccine has actually been assessed from the preclinical vaccine development. So in the preclinical trials, they injected mosquitoes artificially with the dengue virus. And they have shown and observed that the virus actually replicated very poorly in the mosquitoes. Therefore, it is not able to mount sufficient antibodies or sufficient response to be able to transmit the infection. Right? What about the theoretical risk of viscerotropic and neurotropic disease that may take place after vaccination with chimeric vaccines because of the yellow fever vaccine 17D component, which is the base? The fact is that the chimeric vaccines, including your JE vaccines, replicated prominently in studies done in vitro in the skin and lymphoid tissues. However, it spared the vital organs. Thus, these studies have shown that, in fact, the chimeric viruses display lower growth compared to the yellow fever 17D in the hepatic cells. So this was done in vitro, even in hepatic cells. Now, the chimeric viruses are not neuroinvasive. That means they cannot cross the blood-brain barrier, and that they are less virulent than the yellow fever, neurovirulent rather, than the yellow fever 17D vaccine after direct inoculation. So you will see that in the previous studies among monkeys, hamsters, and mice, they have shown that there is very poor replication. Therefore, the mosquitoes will not be able to mount to be able to transmit, and that they have not seen any invasion of the central nervous system, nor did they see any neurovirulence. Now, the risk that severe dengue is higher in those vaccinated upon secondary infection is another concern. Now, remember that severe dengue is actually of a multifactorial origin. The severity can actually be linked to many, many other factors. For example, you look at the virus virulence, you look at the serotype of the virus, you look at genetic determinants in the host, and there can be other host factors, comorbidities, co-infections, and age. So there are so many other factors that may be related. Remember that the first episode of dengue can also be severe. So it doesn't necessarily have to be a second infection for it to be severe. So severe disease may actually occur even with primary infection. So just like the gears of an equipment or a clock, you will see that severe dengue is actually caused by many, many, many factors, and like viral factors. They can be epidemiological factors and risks, such as vector density, the endemicity, of course, the number of susceptible persons. And then, of course, you look at individual factors as well, the host, the age, the origin, health status, etc., and even the risk for secondary infection. Another concern is the increased risk of severe disease may be caused by antibody-dependent enhancement. We say theoretical risk because as far as I can search, there is no actual evidence. So this though remains to be a theoretical risk, and it is still a possible risk. Although the studies have not shown any of this to have happened, for example, because they've seen that ADE has been demonstrated in vitro with primary cells or cell lines. However, they did not show any correlation with disease severity, and that pre-existing in vitro ADA levels were not correlated with disease severity upon natural infection. And this was shown by Watana. And similarly, in a study by Librati, where they looked at dengue infection in infants. And remember that a dengue infection in an infant is considered to be a secondary infection because the first infection is the maternal antibodies to which this infant has been exposed as passed on by the mother. And in that study as well, they did not see any correlation with ADE and disease severity in infants with dengue-specific maternal antibodies. So in vivo observations actually do not support a potential role for increased ADE in vaccinees as compared to that of placebo. But like I said, of course, this still remains to be a theoretical risk and should not be taken aside. There were also in the data available, there were no differences in immune profiles between hospitalized vaccinees and placebo, and that there was no excess in cytokines that were deleterious, which would actually rule out excess ADE. Because as you can see from the data, there was no significance between those vaccinated and those in the placebo group as far as the cytokine levels are concerned. Similarly, if you look at the patterns of hospitalization, including severe disease, it remains similar to that observed in the control group as well. So there is no difference again. And therefore, there is no increased breakthrough viremia in vaccinees compared to that of the placebo. The fact is that there is continued reduction of hospitalized dengue cases from 9 years and above. So this is the data that we see. And this is based on the Asian efficacy trial on their follow-up, year 3 and year 4. Year 3 is the first year of follow-up. Year 4 is the second year of follow-up. Even in Latina, in the efficacy trial in the Latina countries, and even the proof of concept in Thailand. From the clinical standpoint, in the study, in the evidence that is available, there is no significant difference as well in the clinical picture. There was no increased viremia and no cytokine pattern that was associated with increased disease enhancement in the vaccine group versus the placebo group. If you look at the long-term follow-up among hospitalized virologically confirmed dengue cases in subjects 2 to 14 years, age group, you would see that the relative risk actually decreased from year 3 to year 4. Although you will see that in the more than 9 years of age, there seemed to be a slight increase from 0.57 to 0.73, but still is below 1. But if you look at the cumulative risk, you will see that the trend is really going down. The elevated risk among vaccinated children were seen primarily in the 2 to 5-year-old age group, particularly during the first year of follow-up, which is year 3 of the study. However, this risk was shown to diminish in year 4 and year 5, so that the trend in relative risk against dengue hospitalization actually wanes with time. So how can you explain this? A plausible hypothesis is that there could be a relationship of age, serostatus, or in fact both age and serostatus. Vaccination may actually prime the immune system that is very similar to that of natural infection. And after a period of cross-protection, the immunity now actually wanes. As you will see, seropositive individuals, the response to a first natural infection will be considered as a third or a later infection because they are seropositive, which means that they have been exposed before. Among seronegative individuals, the response to the first natural infection will be considered as the second infection, and as we know, this is usually, we say that it is associated with a higher risk of serious disease. The actual data shows that the excess risk is greatest in year 3 among those 2 to 5 years of age, and this in fact even diminished in year 4 and year 5 of the study. Remember, we said that age and serostatus may be a factor. Age could really be a factor. It is a surrogate of prior exposure, because the older the age, the higher the chance that this child has actually been infected. In the Philippines, with the limited data that we have, the seroprevalence rate for those more than 9 years of age is about 89%. And if you remember the recommendation of WHO, if a seroprevalence rate of at least more than 70%, then one may actually implement dengue vaccination programs. Qualitative differences in the immune responses could also exist according to age. Remember that the older the individual, the more mature the immune response, the more mature would be its vascular system, so probably lesser vascular leakage, and the more mature are its physiological ability to respond, the immune response of the individual. The immaturity at both the physiological and the immunological levels may actually exist up to age 10 years. And this may actually impact the quality and efficacy of the vaccine in the younger age group. Now, what about serostatus? We say that it could be a factor, okay? And vaccinating children, young children, let's say the 2 to 5 years old or the less than 5 years, 5 years old, who are actually more prone to have seronegative status because they have less exposure, may actually be a factor. The seronegative status is more likely to occur, like we said, in younger children, and that vaccination may actually present itself as an attenuated subclinical primary infection, so that a subsequent infection is thought to be a wild-type infection, could be analogous or maybe similar to a secondary infection presenting a higher risk of being severe. If we look at the data, you look at the serostatus and vaccine data, we note that in the study, even among seronegative individuals, there's a 52% vaccine efficacy amongst the seronegative, although higher of almost 82% in those seropositive. So we can see that there is a difference in the immune response of those who are seropositive and those who are seronegative. It looks like that amongst the seronegative, particularly in the younger age group, there is a lower quality of immune response, and there may be a rapid waning of antibodies. However, looking at an analysis of the newer data and the long-term follow-up data that is available, it seems that there is a trend for an independent impact of age amongst the seronegatives. So you will see that amongst the more than 5 years old, the relative risk is about 0.9, and among the less than 9 years, it's 1.7. Okay. Now, the other factors could be interconnected apart from age and serostatus. There can be the immune response and, of course, the waning of immunity. Let's look at age. Like we said, the younger individuals may have a more immature physiology, more immature immune response. They may have a more leaky vasculature or vascular system, and that the older the age group, the more likely that this patient may have been exposed to a previous dengue compared to the very young or the younger ones who may not have exposure to the dengue and therefore are seronegative. Let's look at waning. Waning occurs in all vaccines. However, this stabilizes with time. So this is true for all vaccines. After vaccination, they wane and then they stabilize. What about serostatus? As we said, the younger the individual, the more likely the individual is seronegative compared to the older individual. So like I said, there's probably a lower quality of immune response in the younger ones because of the immaturity. What about immune response? Like we said, there's probably a lower quality of immune response compared to the older ones. Okay. Now, the Global Advisory Committee on Vaccine Safety has had assessment of the dengue vaccine in June of 2015, and they acknowledged the increased relative risk of hospitalized dengue in year 3 amongst the 2 to 5-year-old vaccinated population. They also highlight the importance. Oh my, 2 minutes na lang. They also highlight the importance of understanding the potential factors that are associated with increased risk. They recommend monitoring the risk of severe dengue among individuals who are seronegative, and they recommend a robust surveillance with emphasis on a history of previous exposure or previous disease and a history of vaccination. And when they looked at safety assessment, the dengue vaccine is well tolerated. The serious adverse events were similar across the vaccinated and the placebo group. And of course, they recognized the hypothetical vaccine-associated viscerotropic and neurotropic disease risk. And they did emphasize that understanding the potential factors associated with the increased relative risk of hospitalized and severe dengue among some trial participants is a priority. So it's important that we continue with long-term follow-up. Okay, now if you look at recommendation, existing planned efficacy trials will include careful assessment, etc. And all this data will actually contribute to a greater understanding of the potential risk factors and immunology of dengue infection and severe dengue post-vaccination. Okay. The risk that increased hospitalization in the less than 9 years old may actually occur in the more than 9 years old. However, the data that we have, the evidence that we have, that shows that there is no increased hospitalization in the more than 9 years old. In the vaccinated children more than 9 years of age, they continued to have consistent reduction in hospitalization and severe dengue, at least for 4 years from dose 1, so up to 2 years of follow-up, which is year 4. The imbalance amongst the less than 9 was actually restricted to the 5-year-old age group. Okay. So here you will see that the hospitalization of dengue in the 9 to 16, you know that in year 1, year 2, year 3, year 4, there has been a decrease. Okay. Now, they say that seronegative individuals are prone to severe disease. Okay. Dengue zero status is available for almost more than 5,000 subjects who received at least one dose of the vaccine in phase 2 and phase 3 clinical trials across all ages in both endemic and non-endemic countries. And the results showed that there was no effect of baseline flavivirus serostatus on dengue vaccine reactogenicity. So overall, the safety profile after each dose was shown to be consistent regardless of the subject's age, gender, country, or even dengue baseline status. Now, what about long-term follow-up? They say that long-term follow-up is because of the risk of severe disease in the trial. Actually, long-term follow-up has been incorporated in the plan even before the clinical trial started. And this is in accordance with the World Health Organization's guidelines in the development of dengue vaccine, that efficacy trials should include at least 4 years of long-term follow-up. So this long-term follow-up has been there in the plan even before the clinical trials actually started. Now, serotesting is recommended prior to use. The vaccine has actually shown in the studies available, in the data that is available, vaccine efficacy regardless of serostatus. Remember, even among seronegatives, there was a 52% efficacy. In the recommendation of WHO, it did not stipulate the need for individual serotesting prior to vaccination, nor was there an absolute need for seroprevalence data before introducing a dengue vaccination program. A combination of seroprevalence, surveillance data, programmatic factors should define the target population. Remember I said that other epidemiologic factors could sustain transmission, disease incidence, circulation of all 4 serotypes, that it's local, not domestic, not imported, not domestic, but not imported, etc. But of course, if an individual wants, and because remember that it is important for us to communicate to our patients the benefits and risks and the availability of serotesting, it is important so that patients will have an informed decision to make. Likewise, when we look at conclusions on individual testing prior to vaccination, we know that there are limitations of available tests, because to be able to determine that the infection is actually due to the dengue virus, you need to do your plaque reduction neutralization test. This is very expensive, and it costs, like at RITM, I know it's very limited, I think it's only in RITM, it's labor intensive, and it costs about 2,600 pesos per serotype. Okay? So this will actually be a logistical challenge in implementing serotesting prior to vaccination. But of course, like we said, it is available, and if the physician decides that she wants to do it or the patient wants it, then by all means one can do it. But like I said, if you really want to know that it is dengue, then it has to be a PRNT. Now, these rapid tests are available for diagnosing acute infection. They're not designed to detect previous infections. Okay? There are many diagnostic tests that are available, but generally the most practical diagnostic option available is antibody testing. But yet again, I said this is not really very specific. So these are some of the tests that are available, long list here. And now, when in a recent bulletin of the WHO, published in November of 2016, although schedules are already in place in countries, and countries are the ones who decide whether to implement a vaccination program, they believe that the implementation or deployment of vaccine poses a novel logistical and administrative challenge. They said that the apparent association of vaccine efficacy and pre-vaccination status may actually force schedules to be set on smaller geographical scales. Remember, WHO recommends that you have a seroprevalence of at least 70%, then you may actually implement dengue vaccination programs. And this will actually complicate vaccine delivery and increase cost, because the health workers are used to doing this, and then all of a sudden they have to do this particular area lang na ito lang ang gagawa ng bakunang ito, yung sa iba hindi. And authorities will need to explain to the public why some communities are immunized and others are not. This will actually provoke a public concern and may cause confusion among the public and health workers. And of course, the availability of the vaccine may sometimes discourage political and financial commitment to vector control, surveillance, and other preventive measures. That's why it's important that even if vaccine is available, this is only part of the total global program for dengue control and eradication. And then the balance between the expected benefits and identifiable hazards is very complex. Naive individuals may not have as clear benefit as those with seropositive status. And communicating this dilemma to the public may actually discourage uptake. However, concealing the information could severely damage public trust. So it's very important to communicate to your patients. And the WHO established a pre-qualification program to assure the safety and effectiveness of vaccines. And as this program evolved, reliance on national regulatory authorities became the cornerstone of trust-based system in the procurement of safe and effective vaccines by United Nations agencies. Recognizing then that solid regulatory capacity is crucial, the World Health Organization is bent on strengthening the global regulatory framework of vaccines to be able to get safe and effective supplies for countries that procure vaccines from UN agencies. Looking at vaccine risk is not enough. You need to look at the benefits and risk of vaccines. So with the dengue vaccine, the number of cases, the reality is that the number of cases have been increasing for the last 50 years. And the World Health Organization recommends that we consider vaccination in national or subnational epidemiological areas where you have a seroprevalence of more than 70%, or you can use other epidemiologic markers, and that the dengue vaccination program should be a part of a comprehensive dengue control strategy. So countries must realize that not just because the vaccine is available, that's it, we forget about vector control. No, this is only one of the comprehensive things that are included in the WHO control for dengue. And if you look at the vaccine benefits, as mentioned earlier, there is a 65% protection against symptomatic dengue, 80% against hospitalization, and 93% against severe dengue. The potential risk, like we said, are the safety signal, which was seen in the 2 to 5 years old. The ADE, or the antibody-dependent enhancement, remains to be a risk, but this remains to be theoretical because so far there is no evidence to correlate ADE with disease severity. And neurotropism and viscerotropism should still be in our minds because it still remains to be a theoretical risk as well. So from what we see and what we have, the data that we have, it seems that the vaccine actually, the benefits of the vaccine still remain to outweigh the risk, or continues to outweigh the risk. Let me just mention one misconception about vaccines. They say that vaccines cause many harmful side effects, illnesses, and even death, not to mention possible long-term effects. In fact, a child is more likely to be seriously injured by one of these diseases than by vaccine, and that benefits of vaccination outweigh the slight risk, the injuries, and death that occur without vaccines. Remember, with polio, the reality that vaccine-associated paralytic polio is very true, and yet we continue with the vaccine because we know that it decreased disability and death. Not to use vaccines is actually unethical, unforgivable, and inhuman because we know that vaccination saves lives. So comparing the risk from disease and risk from vaccines, again, this was shown earlier, you will see that there are more complications that we get from getting the actual disease than when we get vaccinated. So this is just, I think Julius will show this, so I just want to show that there are no safety signals, at least after the first dose of our school-based immunization program, and these are some of the minor Kay Julius na to. Okay, round 2, ganun din. I just wanted to say that kasi nga vaccine safety, that there were no safety signals that were seen in the first round and the second round, the dose 1 and dose 2 vaccination in the school-based immunization program of the Department of Health. Now, I was lucky to get a copy of the adverse events that were reported in Parana, in the Ministry of Health in Brazil. This was one of the communities where they actually implemented dengue vaccination, school-based dengue vaccination as well. And these are some of the adverse events that they've seen: headache, myalgia, nausea. They also see fatigue, arthralgia, etc. So most of these are minor adverse events. So again, no vaccine is without risk. We need to balance scientific evidence of benefits, cost, and risk when we recommend vaccines, because we know that vaccines actually protect against infectious disease and therefore will save lives. The practitioner has the responsibility to listen, understand the patient's concerns, fears, and beliefs, and we need to strengthen the bond and trust between the patient and the provider. Like I said, it's important to provide patients the most accurate information, what is available. You need to discuss the benefits and risks so that the patient can have, or the parents will have, an informed decision to make. Let me just end by saying that the pessimist complains about the wind. The optimist expects it to change. But the realist adjusts the sails. Thank you very much.